So here's a brief introduction of CATIE. I'm sure most of you know CATIE really well, but for those who don't know, CATIE is Canada's source for HIV and hepatitis C information. It's a national not-for-profit organization working for more than for more than 20 years. CATIE connects people living with HIV or hepatitis C at-risk communities, healthcare providers, and community organizations with knowledge, resources, and expertise to reduce transmission and improve quality of life. CATIE's hepatitis C work with ethnocultural communities started at the end of 2010-2011 with support from Ontario Ministry of Health and Long-Term Care. Components of this project has been nationalized with support from PHAC funding, especially the resource distribution that happens from CATIE's ordering center that happens through PHAC funding. Initially, the goal of the project was to develop linguistically and culturally tailored information resources for the large immigrant communities living in Ontario. The initial work was with four cultural communities: Chinese, Punjabi, Pakistani, and Filipino. The rationale behind selecting these communities was that if the prevalence is high in the countries of origin and the immigration to Ontario is also high from those countries. So on these basis, these four communities were selected. And initial resources were also for these four communities, and so was the community engagement. But now we have online resources in 9 languages, print in 6, and direct community engagement with 5 communities. The project has a 3-pronged strategy. The idea is not to miss out to people in any way. We have multilingual resources which are available online and also from CATIE's ordering center. Then we do direct community engagement through community organizations. But then we also try to work through ethnic media just to make sure that we can reach out to as many people as possible. CATIE's multilingual resources. As I said, we have 9 languages on our website, basic Hep C pamphlet in 6 languages, and some of those pamphlets are on this table, so if you want to grab a copy, you can do that from here. We have an educational tool, which is a puzzle, and some of you have pointed out about the difference between A, B, and C, and the confusion which people have about it. So in that sense, it's a really great tool, and I will talk about it a bit more. Yourlanguage.hepcinfo.ca is CATIE's website for this project. It has these 9 languages: Bengali, Hindi, Punjabi, Simplified Chinese, Spanish, Tagalog, Tamil, Urdu, and Vietnamese. That's a screenshot of our website. There is a language selection bar at the top, so you can select the language you want to use. These are the 6 print resources which we have. They are in Simplified Chinese, Urdu, Tagalog, Spanish, Hindi, and Punjabi. If you look, and the numbers, they show the distribution which we have done of these resources across Canada. If you look at Spanish and Hindi, the numbers are really low because these resources have just been added to the ordering center. We added them this year, and we are working on more resources. This is the puzzle that I was talking about. This is the English version, but we have it in English, French, and 4 other languages, which are Chinese, Urdu, Punjabi, and Tagalog. And we are working on the Spanish version of this puzzle. It is basically for frontline workers and people who are engaged in direct education work on Hep C with communities. So it's a really simple way to describe differences between Hep C, A, B, and C. It's very easy for people to understand through this puzzle. I briefly wanted to talk about the resource development process. All the resources which we have produced under this project, complete ownership of the process is with communities through community advisory councils, and the people who are in these community advisory councils, they are the people who are working in this field with these communities for a very long time, and they are community leaders, and they have a lot of credibility in their communities. All of these resources are medically and community reviewed by the native speakers of these languages. In terms of medical review, a lot of people who medically reviewed these resources, they are medical doctors from these countries. And as a part of CATIE's knowledge exchange mandate, these resources are available to frontline workers, community organizations across Canada, free of charge. So you can order them if you need. In terms of our community engagement work, in terms of our community engagement work, most of the time our work is through community organizations and frontline workers. We offer capacity building opportunities to people who want to do direct Hep C programming with these cultural communities. But other than that, at times, CATIE also does organize direct information sessions and workshops for these communities, and we will talk about that a little later in this presentation. It is because of the specific challenges which some of the organizations face, which engage with immigrants and newcomers because of their funding, especially in terms of reaching out to newcomer population. One of the major way is to reach them through settlement sector organizations, and organizations who receive their funding through CIC. They have certain restrictions, and it's not easy for them to engage everybody, all the immigrants, because as soon as you cease to have your PR card, you cannot be serviced by those settlement sector organizations, and in challenges we will talk about that. CATIE also does advisory role to other groups who are working on Hep C with these communities. But most of all of our work is heavily dependent on a very high-skilled team of community facilitators. And these are some of the community facilitators. Many of them are medical doctors which are trained back home. And here they are either in the process of getting a license to practice in Canada, or because they sort of never opted for that, so they can't practice here, but then they engage in health promotion work. But in terms of the training and work which we do in order to prepare them and do this work, it is a very intensive process. We offer them really intensive training. The training which we offer to our community facilitators, it has 3 main components. All of our work is we operate from this social determinants of health framework. So it is rooted in that. So the training which we offer to these community facilitators, it has a major component on social determinants of health. Then we also, Hep C basic information, of course, we give it to the participants, but then a lot of time in these trainings is spent on developing their language around stigmatized topics of sex and drugs, how to address them in culturally sensitive ways. So that's where we spend a lot of time. These community facilitators, as I earlier said, they are very, very high-skilled people trained back home. They are medical doctors, social workers. A number of times they can't, most of them are newcomers to Canada. So when they first come to Canada, they can't choose their credentials because they are not accredited. So in that sense, working with CATIE provides them this opportunity to use some of the skills which they have. So far, the community education and outreach work which we have done, CATIE has done 43 workshops in partnership with local organizations across Ontario. We have done workshops in Ottawa, Windsor, London, Kitchener, Guelph, Vaughan, and many parts of the GTA. The first part, the training or information session which we do with these communities, first part of that training is spent on immigrant health issues, again from a social determinants of health perspective, reason being that if we get into direct Hep C education, it won't be so relevant to these people's experiences because their lives are largely shaped by their experience of migration. And they have so many other pressing problems on their mind that talking about Hep C directly doesn't make so much sense to them. In terms of evaluations and the feedback which we have received from the participants of these workshops, people find them very, very useful and relevant, and it has increased their knowledge about Hep C and their ability to respond to the issue of hepatitis C. In terms of accessibility, we want to make sure that everyone can participate into these workshops. So all of our workshops are facilitated by the native speakers of these languages. So as such, there is no language barrier, and these community facilitators, they can respond to any queries, any questions that people might have. All of the materials are in language, from PowerPoint presentations to educational tools to things that we use for group exercises. Everything is translated and is in those languages. Other than that, we provide food in the workshops. We offer transit fares and also childcare subsidies, just to make sure that nobody is left out. We try to do them in community places where people naturally gather, as close to the communities as possible, just to ensure that everyone can attend those workshops. These are some of the outreach activities that we have been doing.
Fozia went through a number of levels of approach, reaching people with resources and direct outreach and workshops. Initially, this project was a part of the Ontario Hepatitis C strategy, and a large component of it was a media outreach strategy. So we actually worked with a lot of ethnic media in our first 3 years of the project. So working with media in this sense, it was leveraging editorial, placing advertising in media campaigns, and we also did radio and television talk shows, PSAs. And last year we actually planned a South Asian dialogue with journalists to get some more editorial coverage on hepatitis C as well. So we've actually run 3 waves of media campaigns so far. We initially worked with an agency to develop relationships with the media landscape across the GTA. So we started with 26 outlets, and in our working relationships with them in the first 2 waves, we bounced editorial content off of them. We worked with radio. We also produced television. And in our 3rd wave, we were able to narrow it down to about 16 outlets where we were seeing results. And this included web traffic, phone calls to an info line, relationships where they were willing to run our content and have a dialogue with the community as well. So here's some examples of ads. And actually in the development of the media campaign as well, I took the opportunity to take some novel approaches in terms of teaching media literacy to newcomer and immigrant groups. It was really interesting to talk about how healthcare is sold to different groups, often with fear in different ways. So we had focused discussions, playing commercials, showing them print ads, and getting critical feedback on what the tone in language should be around developing ads. Fear doesn't work very well. Often like to have direct messaging. So here's some of our first ads that we put out. So there is a cure for hepatitis C, and the other language is Tagalog. And we were saying the cure word in 2013 and comfortable with that, and putting that out in terms of engaging people and thinking about hepatitis. The next one is an Urdu language ad with the family. We also focused on families and community messages to engage them in thinking about their health and sustainability too. A healthy community begins with you. Fozia, I wanted you to put a screenshot of you anchoring a show. Anyway, I think I actually have a video of, so we've done some community TV as well. Fozia is actually a stone cold community political commentator with her own show on Revolved TV every Sunday, if you want to look her up. She does great work there. And I have a first version of a video that, it's the long version at 1 minute, that can also be adapted to be a 30-second PSA. And this is working with one of our Urdu community facilitators, whose name is Aliyah. This is not done. We still need to put the Urdu language stuff in, but this is just some of the stuff that we're working now to make our website a little more friendly too. Volume's good?
मेरा नाम आलिया है। आज मैं आपको एक अहम बात बताना चाहती हूँ। मुमकिन है कि आपको हेपेटाइटिस सी हो और आपको इसके बारे में इल्म ही ना हो। हेपेटाइटिस सी एक जिगर की बीमारी है जिसकी अलामात सालों तक जाहिर नहीं होती और ना ही आप अपने आप को बीमार महसूस करते हैं। हेपेटाइटिस सी की तशखीस सिर्फ टेस्ट के ज़रिए ही मुमकिन है। जल्द से जल्द अपना टेस्ट कराइए। मज़ीद मालूमात के लिए इस वेबसाइट पे जाइए yourlanguage.hepcinfo.ca। CATIE कनाडा भर के लिए HIV और हेपेटाइटिस सी की मालूमात का एक अहम ज़रिया है।
And back at it. Okay, so that's a video we're working on. We're trying to produce that in our 4 core languages within the program with different lengths of it. And you saw some of the earlier design within the program. Our pamphlets too are kind of this messy travel desk, and then our website looks more like our key messages now, like this get tested message associated with colors. So partnerships have been really core to the work that we do. Traditionally working in English and French, CATIE didn't necessarily have the partnerships on the ground to mobilize this kind of work. So in earnest, I looked up approaches and approach groups and was captain cold call and actually got some good response around people to support developing these materials. So initial translations were long and not easy, but we had to develop groups for accessible languages that wasn't derogatory. So some important partnerships have included resources like Public Health Toronto's AIDS and Sexual Health Info Line. So they're a multidisciplinary info line team that offers counseling around HIV, sexual health, and hepatitis. I believe there's telehealth resources across provinces that may be able to offer the same, but we developed a relationship with their team, especially around doing media campaigns and radio ads and seeing the response that they got in terms of phone calls. So we got some good info around, say, Chinese forums that had a lot of traffic that resulted in hits, and also radio ads for certain groups, like Punjabi cab drivers that ended up calling in quite a bit, especially because of the age group too. We've also worked a lot with places of worship and faith-based groups. This is an area where I sometimes sense people being uncomfortable about talking about bringing drugs and sex into these spaces. It's a kind of racism to be wary of that kind of religious conservatism, because with cultural ownership and trained facilitators that can relate these things to ways that people understand and make sense to them, we've been able to bring conversations about risk reduction, substance use, and sexual health into mosques and gurdwaras and within Catholic immigration as well. Like an example, I think we talked a little bit about fatalism today and how that can play out in immigrant groups. There's a Filipino saying, it's bahala na, and it's leave it all to God. I can't really do anything about that. And having a facilitator kind of speak at length about how people have control over the choices and the access to healthcare, and that they have a right to prevention, can be really powerful in the face of sayings like that. So in our facilitator training, we've had people relate it to their Muslim faith, their Sikh faith, and it's really beautiful to write down. I get really excited when I have a new way or analogy to talk about how to relate this to groups. Another in relating to immigrants' experience in raising their kids here, and maybe the things that they escaped or the experiences of healthcare or violence in their country, is that they were served a meal that they have no control over, and now they get to choose what they serve to their kids. And that transition in information and care and choice within this culture has been a real turning point for people to really discuss things openly. And also ethnic media. So here's some pictures. This is a mosque in Vaughan, and also, I believe, Windsor in London?
Yeah, the Gurdwaras in London. That's the Gurdwara in Windsor, and that's the Gurdwara in London. The mosque above, there's 5 workshops in that mosque for Pakistani Muslim community, and we did 2 workshops in the London Gurdwara, one in 2013, and then they requested another workshop this year, and that's Windsor.
One sec, train of thought. So there was actually a successful testing campaign in the UK working with mosques, and I believe they actually tested over 5,000 people. And that was maybe 3-4 years ago too. So these are great sites for doing this work. So challenges. There's high demand across many communities and languages and provinces, so we are working with 5 core facilitation teams now, doing workshops in different places, and there's just 2 of us. We're trying to produce 1 or 2 new languages a year, but with our resources and capacity, we've been trying to stay focused and also work in some new areas as sustainable. Fozia talked a little bit about the limitations of connecting with the settlement sector, and I wanted to talk about Yeah, so how the CIC funds the work, if people aren't permanent residents, they're often made invisible in statistics, or they're not guaranteed services at all sites. So we talked about access for immigrants and refugees. Another invisible population among this group is temporary foreign workers, of which the number between students and others is over 400,000 a year, coming in and out of the country, so often returning home and coming back, seasonal workers. And that's a risk group that we need to think of as well in terms of health outreach, access, and education. So general practitioners, I'm talking about coordinating with them, building capacity. A barrier that immigrants face in terms of accessing healthcare here is that fee-per-service doctors are not incentivized to use translation services because they take a lot of time. So we have to figure or do some thinking about how healthcare is structured so that immigrants are guaranteed good access in the language that they're comfortable in as well. And I talked a little bit about the topics of sex and drugs and stigma. You can talk to us a little bit more about our trainings around that. Always happy to share. Now, treatment access is a major issue for immigrants and refugees. Private insurance, stable work. I mentioned like healthcare coverage for temporary foreign workers doesn't really exist either. A lot of folks will just not qualify for treatment too, especially under the current guidelines for liver damage. So in light of better treatments, we're not necessarily going to see more people able to go through the pipeline, especially from these communities. And the interim federal health program, it's kind of yo-yoed and been challenged in what has been coverage in the last year. So we're going to wait to see how that plays out in terms of refugee access to Hep C treatment as well. I think one of the, it's been focused around HIV, especially for access to treatments in that field too. Okay, so lessons learned. So community ownership really helps. It's interesting training a team of facilitators that speak 5 languages in English and saying your job is not to do this well in English. You're here because you speak in your language well, and I'm going to sit in with an interpreter and try to help you as you get trained, but really own it and figure out how to say it. And having them even practice in their own languages without the room understanding is another beautiful thing to watch too, because it's so much easier than kind of the awkward stumbling through that happens sometimes too. The culturally appropriate and sensitive resources. Our content has not been revised in very heavy-handed ways to make it into different sources, and I think that's because of the review that has gone on, and people have been comfortable with our language so far, so we've been able to bring it to different places. I've talked a little bit about working with religious groups. In some communities, gender-segregated spaces are safer for folks to congregate in as well, so we do prioritize working with women and families as well as men. So there's no single way to understand stigma, which I talked about with some analogies, and it varies in different cultural contexts. Wanted to quickly talk a little bit about challenges too, because we often talk about immigrants, newcomers, refugees as a priority population, but within this population, there's groups to prioritize as well. And the organizations serving them on the ground have been important partners in our work too. So these are folks working with older adults around mental health, LGBTQ populations, people working with poverty addictions. These programs have been important because they already have common language and values for accessible services, and it's been important to partner with them as well and keep a lens on those groups as well that need a little bit more reach.
Can I say something?
Please.
Just about this point about gender segregated sessions. All the workshops which we have done with the Muslim groups so far, especially the Pakistani group, they were gender segregated. We offer separate workshops for men and women. And I think those workshops are really important from women's point of view because they feel much more open to ask questions, especially around the issues related to sex and prevention.
Thanks. So we have a community development model that's been running. We are training facilitators each year and doing workshops where we can. It's funny to have a goal of people not staying with us for a long time because we hope that they take their Canadian experience and they're able to work in their field again. So mentorship is really important in this case too. And we're looking and thinking about what that would look like to apply in different places as well. We recently had a national deliberative dialogue and integrated Hep C services and programming, and a number of population level recommendations came out of that discussion, and we're going to have reports on that in the next 3-4 months as well. So we're going to continue working with organizations across the country to coordinate and mobilize efforts around working with these groups. We like to offer a lot of resources. I'm always interested in participating in the discussions as well. And we really feel that a medium-term strategy is needed to enhance the treatment access for immigrants and refugees in this population, especially because of the rapid change of treatment that's happening. Hey, this is mine. So movement building and Hep C. So today I've heard a lot about talking about HIV and comparison of movements, and talking about the different lobbies and their effectiveness. And while I believe it's important to learn from HIV and take that forward, I don't think Hep C is going to match the immediacy and the trauma of that movement and the people that were empowered to stand up and ask for treatment. When we're talking about the primary groups affected by Hep C, it's people who use drugs, immigrants, Aboriginal folks, people who are incarcerated. These are groups not necessarily with a lot of voice, so it's on us, serving them, to advocate across all levels of healthcare access. And it's going to look a little different than what was able to happen with HIV. As a program working in this field as well, we're actually a single-issue health outreach program that we were asked to address wider immigrant health issues because of how those discussions play out in community spaces. So talking about things like the social determinants, of course, but also settlement stress in broad ways, media literacy, health literacy, how folks access healthcare, the language, and also maintain their own traditions and cultures of care. Before we even say hepatitis C, we spend an hour talking about those things, and then we start cracking open the health issues. That's us. If you want to get in touch, that's our contact info. We have some resources here today. I think we have some time for questions. Cool.
I would encourage audience to ask questions because I think you have great experience.
Hi, my name is Raj. I'm from CATIE, the Committee for Accessible AIDS Treatment in Toronto, and you guys all know me. Thank you for such an enlightening presentation. I want to highlight something you said. It's regarding, you talk about migrant workers and they keep coming and going and whatnot. I want to point out that at CATIE, the demographic we serve, we call them, the acronym we use is IRN, immigrants, refugees, and non-status people. And throughout the day today, I have not heard anyone mention non-status people. So I just want to point out that there's a whole demographic there. And you rightly pointed out, nobody talked about migrant workers. There's a whole demographic here that we are not capturing. And it's very important to not neglect this group. I just wanted to point out that. And for those who don't know who non-status people are, people who do not, it means people who do not have status here. They may have come here as migrant workers and continue to stay instead of going back. They may have come here as students and their visa may have lapsed or for whatever reason have not gone back. It could be because there's war going on in the country and they're not able to go back for many, many reasons. And so you have this whole demographic of caregivers as well who are just here and do not have status. And I want to also recap to the morning presentation. I think there's been a couple of people who have spoken about, reaching out to government level and making change from there and pointing out, and I think somebody here said earlier about, it only creates more stigma and discrimination and fear among people when you do pre-screening prior to entry. And I want to point out that a lot of these non-status people continue to choose to remain non-status because of the stigma associated with pre-screening and because of the burden on the healthcare system factor that's involved. And that's why they're not able to transition from non-status to immigrants or refugees. And that's a whole huge topic on itself. So I just wanted to point that out.
Thank you, Raj. Especially around temporary foreign workers and non-status individuals, a large cohort of undocumented folks are going to be staying here just this very April because of reactionary changes to the TFW program. So I know that the CEIC hasn't acknowledged those folks and what they're going to do around services and access as well. And we're going to see how that plays out over the next year. Hi, Robert.
I'm Robert Bartston from Shabaka Canadian HIV/AIDS Black African Caribbean Network. I simply wanted to ask if you can update us on any activities similar to yours with dealing with sub-Saharan languages. And I apologize if there was a disclaimer already about this, but as a black man, I'd like to know that we're being taken care of.
Yeah. A resource development project that happened in parallel to a number of the languages that we covered came out of the Sexuality Education Resource Center out of Winnipeg. And over 3 years, they developed a pamphlet with Hep C information across 10 African languages. And in our own work, in terms of development within languages, Arabic is currently under review, and over the next year, we're working on Somali, having taken a look at the census and statistics of populations too, and also Gujarati to round out some of the South Asian languages that we offer. In terms of programming and community development on the ground, because of the focus that we have on doing in-language work with groups, we've worked with the largest group so far. When we've taken a look at the African languages to start and do this work in, we supported CIRC in their work, and we saw that a lot of folks were actually speaking English and French, and CATIE has very strong French presence there. We're distributing that resource in that language, but I do believe that there's a need for community education and outreach on the ground, because we haven't seen a lot of that within your communities too. Yeah.
Really great work. And just a question. It sounds like that the work that you're doing is primarily around education and screening. And one of the things, being a practitioner, is I wonder about the other piece of treatment and community support in people in treatment. And you know, I know that your group, you're doing that, you're supporting people with disease. But I wonder about that piece, and is that something that that there's plans to expand on, or are there other groups that have that support role with an ethnic focus of different ethnic groups that can help people through their treatment for hepatitis C and encourage them to adhere to treatment and all the other issues around treatment?
Yeah, there's a lot of theories of application in my head and ways that I think to address this, and also not duplicating work. Like the BC CDC's engagement to care resources are specifically going to address that linkage. So we're doing more of the public awareness, and then we have the resources to keep people in care, understand their treatment, and move forward from there. So communication at this level is really awesome. In terms of like the culturally specific supports for immigrants living with Hep C, maybe not accessing the mainstream or in their language. The most funded things for immigrants are language and employment, which is fair. People need jobs to survive here, but there isn't a lot of programming necessarily in health, except at the level of chronic diseases, which are quite widespread. So you see a lot of support for diabetes, heart and stroke, and cancer. Now, out of those movements of work, chronic disease self-management and chronic disease management has been a way for people to collaborate under that umbrella. And like I recently received training from the Chronic Disease Self-Management Program, which runs in each of the LHINs in Ontario. And like in terms of people owning that and peers running their own groups and in earnest making positive change week to week over 6 weeks, I think those programs are a way for people to set up supportive communities where they wouldn't necessarily get one funded across a number of languages. So where a community exists, getting them into those trainings, using workbooks and doing that is something that I can imagine being realistic about. I know that the Canadian Liver Foundation offers Chinese support services and discussion groups across different areas as well, so that's been a group with strong support, but it's hard, especially because immigration's going to change, right? And people will disperse to where there's work, and the countries will change, so the people that will be here 1 to 3 years that are going to deal with Hep C when this treatment is available, what will support look like for them is something we need to problem solve for sure.
Sorry, just a comment, and it's about the comment you made about HIV and hepatitis C, and that although it's not going to look the same as the HIV movement, that it kind of, to me, it feels like we're painting a grim picture. And although it can be a bit grim, I think we need to brighten this picture up, and we can make a lot of movement still. You know, there's a upcoming election, and I think we all need to, and there's a huge immigrant population, and we need to vote in the right direction in order to make any change in policies and in movement, I think, in hepatitis C.
Yeah.